Let's go ahead and get started. It's 11 a.m. Happy Friday to all of you joining us today. For those of you that have just signed on, please give us a quick shout in the Q&A box to let us know that our audio is good and you can all hear us. I see Lance is on. Hi, Lance. While you're doing that, I'm going to take care of introductions. My name is Kendall. I'm going to be your host today, so welcome. Thank you for joining us. We're scheduled for 50 minutes of content with about 10 to 15 minutes of Q&A. So speaking of Q&A, you will have an opportunity at the end to ask Dr. Margeas questions, so please don't be shy. The box will remain on the screen and you can type questions in any time. Also, if you have technical issues, please let us know. Cody and Taylor are working in the background to make sure that you all have a really great experience. Recording, we will send the recording later today with CE info, as well as post it to the CONNEXT webpage. So if you haven't visited the landing page yet, that's where you can find the library of all of our past CONNEXT courses, as well as handouts. So we'll post the link in the note box on the screen so that you guys can grab it, and you're welcome to go back there anytime. Okay, it is my pleasure to introduce our presenter today, Dr. Bob Margeas. Dr. Margeas maintains a full-time private practice focusing on comprehensive restorative and implant dentistry in Des Moines, Iowa. He is currently an adjunct professor in the Department of Operative Dentistry at the University of Iowa, and he is board certified by the American Board of Operative Dentistry. He's written numerous articles on aesthetic and implant dentistry and lectures and presents hands-on courses nationally and internationally on those subjects. He is also the editor-in-chief of Inside Dentistry. He's on the editorial board of Compendium and is a contributing editor to Oral Health in Canada. So we're excited to host him today. And before we jump into it, I also want to introduce another guest host we have on the line. We have Dr. Cooch joining us again. He's the founder of Carie Free and an internationally recognized speaker. He's also published hundreds of papers on dental caries in various dental and medical journals. So let's get into the fun stuff. Dr. Cooch, I will let you officially hand it off to Dr. Margeas.
Hey, Kendall, and thank you so much. And Bob, I just want to thank you so much for taking the time to do this out of your schedule, because I know how busy you are. For those of you who don't know Bob or haven't seen him present, I just want to tell you that he's one of my favorite people in the world. He is gifted. He's not only my editor at Inside Dentistry, but he's an individual who is exceptionally talented, but he works exceptionally hard as well. And so he's just a talent, and he's a blessing to our profession. I'm going to just quote John Coyce here, and this pretty much sums up Bob Margeas for me. John once introduced you to an audience I was sitting in, and he said, "If you don't like Bob Margeas, we can't be friends." And that pretty well says it all for me, Bob. So I am so excited to see your presentation. Take it away.
Thank you very much. It's nice to be here. I apologize to Kendall that I've been so busy. I did 4 webinars yesterday with hands-on programming and things like that, that over the last 6 weeks, I think I've done about 20 webinars. So it's my pleasure to be here today. It's fun for me to do it. I'm here in Michigan. And, this COVID virus has really been, scary. One of the positives that have come out of this is, as a lot of you know, that know me well, that my wife lives in Michigan and I live in Des Moines. And I work 3 days a week in Des Moines. Then I fly up to Michigan and see my wife. Because when we got married 6 years ago, coming up, she has 2 children. I have 2 stepkids. They couldn't move to Iowa. So I make it work where I work Monday, Tuesday, Wednesday, hop a plane Thursday, and fly into Detroit. The downside of it is right now, as I look at the flights, I have a direct flight from Des Moines to Detroit, but now it's a connection for a while because there's not enough people flying. So that's going to be a downside. But let me get into the presentation, and I'm going to show numerous cases of treating cases in my office on an everyday basis. This first case, I was fortunate enough to work with my good friend John Durango. John Durango and I treatment planned and did this case together from my office. He came in from LaSalle, Illinois, and we worked on this case. And when you look at a case like this, when patients come in with wear, you have to make a decision: what caused the wear? Was it attrition, erosion, abrasion, abfraction? And how are you going to treat these? Because everything looks a little bit different. So when I look at this case and I look at the gingival margins, gingival levels, and if you listen to Bill Robbins talk about the 5 key determinants of a gummy smile or gingival smile, you look at, I would expect the cuspid free gingival margin to be basically on line with the centrals. When you see a case like this, you see that there's a discrepancy in the gingival levels, which means that it's possible that these teeth, as they wear, they super erupt. And if they super erupt faster than they wear, the patient has maintained their vertical dimension. If they wear faster than they super erupt, then they lose vertical dimension. But when you have a case like this, you have to start somewhere on how are we going to restore it. Because when you look at this case from the lateral view, you can see that there's wear where the teeth don't touch. They have abfractive lesions, non-carious cervical lesions. And when you look at the lateral view, you can almost see that the teeth are in retroclined position, which means that you could have a little bit of a wear due to friction of these teeth. But overall, what has caused this wear? You really can't tell until you look at the occlusal view. What I want to show you here is there is a step, a distinct step between the cuspids and the bicuspids on the lower arch, which gives me the idea that I may be able to have room to open the bite on one arch versus 2 arches if I'm going to, in fact, change the vertical dimension. And we'll get into that as we go along. When the patient goes laterally, you can see that there is disclusion of those teeth in the anterior and the posterior on those cuspids. But when I look here from the occlusal view, you can see the amount of wear here. Some people may say, well, this person is a bruxer, or this person is a grinder. But if you know the different attrition, erosion, abrasion, abfraction, the different key determinants, you can see that this is more of an erosive type lesion. And what caused the erosion? Is it extrinsic? Is it intrinsic? Either the patient is regurgitating acid, or is it something that he's ingesting? So when the patient came in, he says, I'm concerned that my left lateral could break off at the gum line because it's really, really thin. And I said, yes, it could. And he says to me, I would like for you to only do the front teeth. I don't really want to have my back teeth done. They don't bother me. We get that a lot. And there are a lot of times you have to let the patient know that you can't always just do the front teeth. And a lot of times what I'll do is I'll take composite, I'll roll it in a little convenience form, put it on the lingual, light cure it. And then what I'll do is I'll show the patient a mirror and I'll say bite. And they'll say, oh, this is just perfect, doc. But when I bite, I'm only hitting it on my front teeth. I say, yes. Now you see why I have to do the posterior teeth. I don't know when I look at cases like this if I can just do one arch or if I have to do both arches. And so in a situation like this, you have to understand where the occlusal plane is. If you use Dr. Coyce's 10 step, the first thing you want to do is know where the incisor ledge position is. You can't send this to a laboratory and just say do a wax up. I need to have photographs when the patient's in repose, when the patient is smiling. I use one of the teeth that I like as my key determinant, and I treat every patient like it's a denture try-in. So if the patient's in a wax try-in, and let's say the teeth are hanging down too far, what are we going to do? We're going to heat the wax up and move the teeth up. That would be orthodontic treatment. If the patient smiled, they showed a lot of gum, what would that mean? Well, maybe I have to take some of the gum away. And so in a particular case like this, I used a Coiste programmer with John Durango in order to get the centric relation position, not to see if the patient could tolerate the bite opening if we're going to open the bite. I just wanted to get a nice CR mounting. Whether you use a Coiste programmer, a Lucid-Jig, a leaf gauge, it doesn't matter as long as you have a repeatable position. So we mounted the case up and we decided on, have the patient lost vertical or not lost vertical? Well, we didn't have a cephalometric x-ray from today versus, years before. So we have to decide where we're going to build this patient. I'm going to describe that as we get into a few more slides. If you look at the Panorex, you can see that the patient has a dentigerous cyst on the lower left with an impacted third molar, and those two teeth had to come out. The patient lost those teeth. I show you the bite wing x-rays. The bone level is excellent. The patient doesn't have any periodontal issues laterally, but you can see that dentigerous cyst on the left. Now, if you look at the models, you can see the extreme wear. And if this was an attrition case, the dentin and the enamel would be at the same levels. You'd have wear only where the teeth touch. When you have wear where there's erosion, then you have to determine what caused that. And as John Coy says, you put your Columbo hat on and you determine what caused it and what restorative material am I going to use here to fix this case. Here's the lower teeth. You can see the amount of wear there. Now, if the patient did not have wear on the posterior teeth and the anterior teeth were the only teeth that were worn, the way I would treat this case would have been orthodontic intrusion. If the occlusion was good in the back and there was no step in the occlusal plane, I would orthodontically have those anterior teeth intruded. We can do that quite easily now with pads. And you move the teeth out of the way, and then you restore the lingual anatomy back to normal. But because the patient had wear and there was a step in the occlusal plane, we felt that we could just wax the case up by adding wax to the lingual. And then what we would do is have close the articulator. And if the teeth weren't touching in the back, we'll just add wax to the posterior teeth. Now, that being said, a lot of times we find that when we do mount the case in centric relation, what do we see? We have an initial point of contact, and then the patient can close and slide into MIP. So let's say we mount this case in centric relation. We have an initial point of contact, let's say it's a bicuspid, and I realize that when I wax the anterior teeth, that tooth in the back still is in occlusion. The patient is not hitting on those wax linguals. I feel like I can just add wax to the posterior teeth and I'm not altering the vertical dimension. But let's say the patient is biting on the anterior wax. What I need to do is open the pin enough in order to get the teeth in the anterior to just disclude and not hold shim stock. I don't want to have anterior contacts and banging on those front teeth. So basically what we did is we mounted the case. The patient's hitting on the wax in the front. That's a reasonable amount of wax to add on to it. And we open the bite with the posterior wax up. We are then going to make an impression of the patient's teeth. We did not prep the teeth. John and I did this just with all additive. This is augmentation versus amputation. So we made an impression using polyether, and then we're going to inject a silicone dye material because I want to make these restorations on a silicone dye so they don't bond or stick to the stone. If I pour this up in stone, I can still make my restorations, but it's sometimes harder to get them off the stone. So we go ahead, we fill that, we heat our composite up, we put this on the lingual, and from that wax up, I made a clear impression with a clear PVS. The clear impression materials from Cosmo called RSVP impression material. And I'm making a replica of the wax up of which I can now, with the composite heated up, push this over the top of that model, light cure through that wax up, and now have lingual veneers fabricated that are made in about 10-15 minutes. Now, I had a silicone, I had the RSVP over the top, light cured it, pull it off, and now I'm curing this in a triad machine. And then we go ahead and polish these restorations with your personal preference of polishers. Now on the lower arch, this clear impression that you see here was made with a non-retentive clear plastic tray. I put the material in the tray, push it over the wax up, take it out of the tray, and now I have a stent that I can go to the silicone dye material, heat the composite up, push this over the top of that model, and fabricate 4 overlays. So I took the clear impression material, pushed this over. The downside of this technique, if you think about this, when I push this over, what is preventing me from pushing this too hard over this model. You need to have unprepared teeth, which here we have a cuspid in the anterior, and we have a retromolar pad in the posterior. So when I hold this, I'm going to hold it on those anterior and posterior stops. I'm not pushing on the middle of the impression, because that can distort it. Now, one thing that I've done that's different, if you think about this and you just follow my words here, when we added the wax to that model, all we did was add it over the top of the teeth. We have not prepared the teeth. So now what I do is I have my laboratory take the center of the wax out of the restorations that we waxed up. Just take the center of the wax out about 2 millimeters and down to the stone, so that when I inject my clear impression material on the wax up, the little nubbings will go into my impression, and the stop will actually be the occlusal surface of my restoration. Now, when I fabricate these, when I took the clear impression off, what would you see in the center of these? You'd see a hole that you would fill in with just flowable composite. And what that allows you to do is have a stop without having any anterior teeth that you have to worry about, or the retromolar pad that's not a firm stop. What we're allowing that to do is let that be our vertical dimension. So how do we bond these in? Well, what we're going to do is we're going to try these in as a group, and then what I'm going to do is section these. I section these using a 943. It's a 943 little disc that is super thin. It's from either Comet or Brasseler, and you can section these so you don't have open contacts. I come from the facial and then I snap the restoration, so I want to still have contact on that. Now, there are many other ways to do this. John and I just decided to do it with composite. You could use Emax, you could use laboratory fabricated composite veneers. Doesn't really matter. The bonding protocol is still very similar. How do we bond these on and not have these come off? We use micro etchers. This is a micro etcher, but I use a prep start today from Danville Engineering, where we want to microblast the tooth to clean it off. And then what I want to do is I want to etch the teeth so that I can bond these on. I'm using a 4th generation adhesive here. The 4th generation's All Bond, Total Etch, OptiBond FL, Scotch Bond Multi-Purpose. It has 3 parts to it. Etch and rinse, keeping it moist. Place a separate primer that I scrub for 15 to 20 seconds. Separate adhesive that I place on there. And then what do I do with my restoration? If it was a ceramic restoration, obviously I would hydrofluoric acid etch it. I would place silane. I would place adhesive on the restoration. Then I would put my resin cement. On these composite restorations, we do not silanate them. We sandblasted them with particle abrasion, put adhesive on that, and then we used a light cured resin cement. You could use heated composite. You could use flowable composite. It really doesn't matter. And then we go ahead and bond it on. Once we bond that on, we clean the excess off, and now we go to the next one and the next one. So once we etch those teeth, I want to show you that there is a lot of enamel to bond onto here, because what did the patient do? The patient wore through all of the lingual enamel, through the dent, all the way to the facial enamel. And I'm going to bond these on. So now if you ask the patient to bite, it's possible that the patient is only hitting on those front teeth. So what do we do with the back teeth? We bond those on by micro etching. We put a rubber dam on. We isolate by etching, placing adhesive. These are just tops. There's no retention on this. This is all mechanical, chemical retention. And we go to the next one, the next one, the next one, until we get them all bonded on. This was just done by John and I, where we just, used the stents to do that. And now we have them all bonded on. And now we want to adjust occlusion. Our goal is to have even bilateral simultaneous contact on all the teeth and be able to pull shim stock out of the front. So we get done. Instead of using a Quest programmer, what we did is we took composite and we rolled it in a ball, and we were going to redo this diastema closure. So we mechanically just put a little anterior platform, and we let the patient tap on that, maybe 10-15 minutes. And then what we're going to do is adjust this. So right now he's only hitting on that like a deprogrammer. You could use a leaf gauge or a Coist deprogrammer. What we're going to do is adjust it until a tooth touches. Once a tooth touches, we'll adjust it. If we don't get even contact, we go back to the platform in the front, go back to the back, and so forth. And that's how we go about doing our adjustment until we see contacts on all those teeth. Now, I normally will do both sides together to adjust the occlusion. For some reason, I was adjusting these while John was making the other side, but I think it's better probably to have both sides adjusted at the same time. But this was not a problem because I got the contacts there, very minimal adjusting. Now, what we do here is, and I learned this at the Coist Center, where we set the patient up, we give them a piece of chewing gum, and I take the Bausch articulating paper, and from cuspid to cuspid, I cut that piece of paper, I let the patient chew. I want to see his chewing pattern and what happens to those if he's banging on the anterior linguals. So as we look at that, you can see there's a little bit of a scuff mark on the cuspids and the laterals. Now, I don't mind having centric stops on the cuspids, but I don't want to have interferences when the patient is chewing. So what I'll do is I'll get rid of all those interferences, and so the patient doesn't have any interferences or scuff marks when he's chewing, because I still want to make sure that he may not be constricted, because sometimes when the patient's wearing and they get super eruption, they can be constricted. And as you know, the only way we can treat a constricted chewing pattern is either orthodontically moving the teeth out of the way or opening the bite. So here's what the patient looks like prior to me now going to do the anterior composites with just direct resin to close the diastema, just a one-shaded composite. Here's what it looks like. So this is all done with direct and semi-direct indirect restorations. I'm going to do the class 5s in composite that I'm just going to do intraorally. And here's the before and here's the after. All bonded using a 4th generation adhesive. This case was done, John and I did this case in 2007. We published it in 2009. And so the patient is here like this. This is what it looks like after. And how much did I really open the patient's bite? Well, when you look at this, 1 millimeter in the back is 3 millimeters in the front. It was not a lot of opening. And so I want to show you the 7-year post-op. When the patient came in, you know, initially I said, do you have heartburn? Do you have indigestion? Do you have any sour taste in your mouth or sour stomach? He goes, no, I feel fine. When we ask our patients, most of the time, when we suspect GERD, they're in denial. They say, no, I feel fine. And so when patients are in denial, what I like to do is I like to put them on Prilosec for 14 days. And then I have them come back and say, do you feel better now having the Prilosec versus before? And a lot of times I'll just say, wow, I never realized that I had an issue. And for me, there's a strong correlation between acid reflux and Barrett's esophagus, esophageal cancer, but also airway. When you have airway issues and sleep apnea, there's a strong correlation between GERD and apnea. And so you have to play crime scene investigator, ask all the right questions. So here's what it'll look like at 7-year post-op, lateral view, and this is something that we do on a regular basis. How's a 9-year post-op? The only thing that ever happened with this case is the patient had chipped an incisal edge on number 9 when he was in Dallas, and he had that repaired down in Dallas. And number 10 at 8 years had debonded. It debonded, but he came back, and I rebonded the lingual of number 10 just by sandblasting the restoration and now using resin cement. He also lost the bicuspid class 5 on the lower left. But overall, here's what it looks like at the 9-year mark. Now, This case this summer will now be 13 years old. We have never replaced any of the restorations, but what I want you to see is look at the wear on that lower second molar. And at 9 years, you know, the composites were still holding up. This is under compression. Composites under compression are actually quite successful. It's under tensile forces that you can have a problem. So what would John say, Coyce? He would say, hey, just retread it. But it's like a new tire. I'll just take that off and put a new one on. And so is this dentistry forever? No. But for us, it's more about, I would rather have a restoration break than have the tooth break off at the gum. So when the patient asks me, well, how long is it going to last? I said to him, I don't know. I really don't know. My goal for you, Steve, is to prevent you from having a catastrophic failure. And he goes, well, what's a catastrophic failure? He says, well, a catastrophic failure, Steve, is when your lateral breaks off at the gum and now you need to have an implant. So when I talk to these patients, I say, I don't know how long it's going to last. If you did this damage to your teeth, what makes you think that my restorations are going to last forever? They're not. Know that this is a maintenance issue. And then they say, is my insurance going to pay for this? And I say, no, it's not. This is a non-covered benefit because of erosion. Insurance doesn't want to pay for. Now, if he said he only wanted to do the front teeth, all you have to say to the patient is just because you don't want to do the right thing doesn't mean I have to do the wrong thing. And you don't do things that patients want you to do when it's the wrong thing. Because when you feel bad for patients, bad stuff happens. And I've learned that the hard way when I've been talked into doing things. So did I make him a mouth guard? No, I didn't make him a mouth guard because he didn't have parafunction. He had mainly erosion. So how do I do this if I'm trying to stage cases over time? There are a lot of patients come in that need full mouth reconstructions, but they really can't afford to have it all done at once. This is where composite resin works well. I tell the patient, in order for me to do this case, do you have $40,000 to spend to fix your teeth? When they go, $40,000? And I said, yeah, if we're going to do a full mouth reconstruction with permanent restoration. I said, well, how about $20,000 over 2 years? Well, I could do $20,000 over 2 years. And what I say to them, I said, okay, we need to have a diagnostic wax-up done. This is what the cost is. If you decide to have treatment done somewhere else, you own the diagnostic wax-ups. But in order for me to do the case, I need to do a diagnostic wax-up. If they said they couldn't afford $20,000 for 2 years, I say, how about this? If we wax this up and we stage it over a 4-year period and charge you $40,000, $10,000 a year. If they say no, they can't even afford $10,000 a year, do not waste your time trying to do a treatment plan and a consultation when finances are not feasible. I talk finances immediately. I ask them who's in the game and who's not. Now, how do I charge for these? Well, if it's going to be a transitional restoration, that they're going to have permanent restorations later on, I say, Steve, I'm going to charge you $500 for these posterior ones. I'm going to charge you my normal fee for a veneer on the anterior minus a lab bill since we made them. And with the $500 you pay towards these posterior restorations, allow me, that's less than half of what it's going to cost to have a permanent one, but I need to open your bite. When you come back in a year, what I'll do is credit you $200 per restorations towards a permanent restoration, but I want to be charged for these because many times I built the posterior up and they didn't come back to have the restorations done. And they kept these as permanent restorations. So it works extremely well. Let me get into the subject on immediate implant placement and provisionalization. I've been doing this since 2004, where if a patient comes in and the tooth can be atraumatically extracted and the implant can be placed and torqued to at least 35 to 40 Newton centimeters, I'm going to restore the case with a provisional, immediately placed provisional. How do we do that? I want the implant placed toward the palate, toward the lingual, where we have 3 millimeters of space between the implant body and the facial plate. I want to have good stability. And then I'm going to have a bone graft placed for between the implant and the facial plate. Now what I do is if the tooth is in good shape, I cut the root off, and what I want to do is use this provisional tooth structure as my temporary. Now this is a Straumann system where they had peak abutments. You can use titanium cylinders. All I'm going to do is I'm going to prep this titanium and peak coated temporary out of the mouth, and I'm going to place that back in the patient's mouth, and I'm going to try this little piece of tooth structure on. What I did is I hollowed the tooth out and I put a hole on the lingual, because now I can seat this over that temporary abutment and connect it to that peak material, because I'm going to use this as a screw retained provisional. Now how do we do that? Well, I put a cotton stick in the access opening. I'm going to push that over the top, but I'm going to use acrylic. I'm not going to use like a flowable resin. I'm going to use actually like a methyl methacrylate or a Duralay, and I'm going to put it on the inside of the tooth. I'm going to form that over the abutment, and with the stick there, not allowing any of that material to go through the screw access hole. I'm always constantly turning that stick in order to not allow it to bond to it. Then I'm going to take a screwdriver, unscrew it, and now I have a job to reline the margins. So I'm going to reline the margins just by bead brushing the acrylic, and then I'm going to have to trim this so that I have a flat or concave emergence profile. I want to have this flat or concave. It's actually better to have a concave versus any type of pressure on the facial. When I seat this, I don't want to have the facial margin be having any pressure on it. Okay, so now we have the implant here that's lingually placed, and what I'm going to do is just screw retain that natural tooth. Now I take the tooth out of occlusion, and my words to the patient are, this is a lookie, not a chewy. It is for looks only. I am doing this as a favor to maintain the contour of the tissue. I take the tooth out of occlusion. I instruct them that if they bite on this tooth, it's possible that they will cause this tooth to fail, cause this implant to fail. So they're very well informed. Otherwise, I say, I have to make you a removable appliance that you're going to have to take out. I allow this to integrate for 3 months. We come back at a 3-month level. Here's what it looks like. And the tissue is a very, very nice pink color. It's scalloped like the adjacent tooth. And now all I have to do is make a final impression, whether you use a custom impression coping, where you use that tooth as a guide and make a custom cylinder, custom impression coping, or you can put the impression coping on right away after I take this off and be ready to inject impression material so that it doesn't collapse on you. Or you put the impression coping on, squirt some flowable resin around it, capture those contours of the tissue. That's for another lecture. But you can see here that we've got beautiful tissue to make an impression of because of this. The contour of the temporary on the day of surgery. It's just a way. Now, if the tooth wasn't in good shape, what would I do? I would use a bisacryl, and I'd use a putty matrix, and I would allow that bisacryl or my acrylic just to stick to this material. So here we have this, where we have the impression coping on, and I'm going to do a snap-on plastic cap and make the impression. Now, what do? The laboratory, I'll take a lab analog, attach it to that impression, and I will then push that back into the impression after I've attached the lab analog. It just sets back in and snaps into the plastic. Now I'll use a soft tissue model. My laboratory will make me a screw-retained restoration. Now it's up to your laboratory how good they are in matching a tooth. We did our job, and now you have to have a lab that can copy this. Here we are on the day of surgery. You can see on the day of insertion, you can see the blanching of the tissue and the blanching of that tissue now. I wait to see in 6 to 7 minutes, does the blanching go away? If the blanching goes away, we're great. If not, I'll adjust that facial portion of that restoration. Here's what it looks like at the 1-year recall, and you can see that the laboratory did a good job of matching it. Patient smile, here's the smile, and they tried to copy the same type of anatomy with a little bit of an incisal chip, and it really comes down to your laboratory technician after that. Let me show you my first one I had ever done. This was the first immediate placement extraction and provisionalization that I ever did. I did this December 29th of 2004 after going to the Greater New York Dental Meeting and seeing Bernard Tuati do his presentation. So this cuspid had to be removed. I'm sorry I don't have the picture of the pre-op, but it was a cuspid that had been failing. So the implant was placed, and this is a Straumann tissue level implant. It would not be my implant of choice for an anterior implant today, but in 2004, they didn't have a bone level implant. That was the implant system I was using. So what do? We get this back from the surgeon with the healing cap on, and now I'm just going to remove that healing cap, and I'm going to take the tooth, and if the tooth is in great shape, I cut the root off, and then what do? I hollow it out. Now, prior to extracting the tooth, I made an impression, poured the stone model up, and I made a little jig that I could set this in to put the tooth back into that extraction site the same way that it came out. So I hollow that out, and now I need to reline this natural tooth. How do I do that? Etch the tooth, place my adhesive, and then what I'm going to do is use my Bisacryl. I'm going to inject Bisacryl, ProTemp, Luxatemp, Integrity, any one of those in that, put it back in my clear or my putty matrix, push that on over the abutment, and what I want to do is try to capture the margins of that implant. After that sets, I remove this, and then I have to have a separate analog out of the mouth that is exactly the same that's in the mouth. So I have to use 2 separate abutments. I'm not going to unscrew this abutment that I had just hand tightened. I'm going to just hand tighten it, and then I'm going to place this with the flat side on my implant analog. This is a similar implant analog that is in the mouth. I set that on there, and then what do? Use flowable resin to capture the margins. So I use flowable here around the edge, and then I'm going to make that emergence profile flat or concave. I do not want to have any pressure on this facial margin or the papilla. So you can see that is a tissue level implant with just a solid abutment. I wouldn't do that today in 2020. I want to do all screw retained provisionals. So I would use a bone level implant here, whether it's a Straumann, Nobel, BioHorizons, similar techniques, and I try it on. And then what I'm going to do is I'm going to take that off. And the way I clean my cement so I don't trap any cement, I'm going to take my analog that I made this on, put the cement in the tooth, push it on the analog. I learned this from Frank Higginbottom out of Texas. Clean the cement off real fast, take it off, and now cement it. So it takes me about 4 or 5 seconds to do that. And you can see on the distal, I still have some cement trapped on the distal. I take the tooth out of occlusion, and here's what it looks like on the day of surgery. Now, at 3 months post-op, he comes back, and this is how the tissue looks. If I said which one's the implant, I think all of you would say it's the one next to the bicuspid, because he's getting tartar actually on the roots here. And he says to me, hey, I've had those other 3 implants placed at the same time. Can I just pass on having this one restored? I don't have the money to do that. Can I do it? I said, sure. So he waits, comes back at 1 year, 2 years, 3 years, 4 years. And at 4 years, I took a picture. Here's a 4-year post-op. This tooth was never restored at 4 years. So I said to myself, well, let's just see how long this will go. So at 5 years, and then at 6 years, I decided to probe the area. And I'm probing here hard enough that I can get bleeding done, and I wanted to show that the tissue blanched at 3 millimeters. You can see the probe causing blanching. So there's a connection to that tooth. So I showed this to John Coyce, and I said, look at this, you know, there's attachment. I can't go down to the implant. I said, it's like maybe hemidesmosomal or something. And he goes, really? He says, you have the histology? And I thought he was serious. He started laughing. He says, I'm not saying there's not a connection. Just don't say it's like hemidesmosomal because you don't have the histology. Just say it's a connection. So I'm telling you here, it's a connection. At 7 years, here's what it looks like. The tooth was taken out of occlusion. The crazy thing about this, I published this in the Journal of Aesthetic and Restorative Dentistry, JERD, January of 06. Now, I've got a 14-year follow-up of a tooth that has never been restored since day one, out of occlusion, because the other teeth did not, they had teeth that were hitting, they didn't super erupt, so he still doesn't have occlusion on this tooth. But look at the bone level around that tooth. No bone loss really up to the first thread. Here's what it looks like in the anterior, and here's what it looks like after the surgery. So this tooth has never been restored. It was never meant to be non-restored, but because it lasted so long, I felt it was okay just to leave it. So I've left it. I'm going to go back and republish this, do a retro study, and showing from day one to where it is today. So let's look at some composites. And when I'm looking at color, I look at hue, value, and chroma. And the important thing amongst all of these different parameters of color really is the hue. I mean the value. Hue is just basically the color itself. Everybody talks about what's the shade, A1, A2, A3. That would be the hue, not the most important of all of the three components. Value is the lightness or darkness of the color, from gray to black or white to black. And so I think it's very, very important to understand, you know, value. How do I check value when you can only see that with black and white photography? What I like to do is I like to take a picture of the tooth with my iPhone with the composite shade that I want to use on the tooth, light cure it, and then I'll take my phone, take a picture, and then I go into the edit mode and go into monochrome. That way I can change the color to black and white. Chroma is just the degree of saturation or intensity of the color. An easy way to understand these three parameters is what? I have 3 glasses of water here. One has 4 drops of food coloring, the middle one has 8, and the right one has 12. If I asked you what's the hue is green, but the one that has more food coloring in it is a higher degree of saturation of color or a higher chroma. When you have a higher chroma, you have a lower value. If you turn it to black and white, it will be darker. So the value is lower. It's very common that when we have a single discolored tooth, we get done with the restoration and the tooth still looks gray. So what do? In order to raise value, you've got to use either a Dentin shade or opacious Dentin if you're doing porcelain, or you have to use opacers. Look at this natural tooth. This is from Margeas, and you can see where the enamel is. The enamel is basically prismatic, and it has, you know, it's more translucent, not transparent. It's translucent. So if we could demineralize enamel and superimpose it back over the tooth, this is what it would look like. You can see that the interproximal has no dentin in it. So if I'm building up teeth, I always want to leave room so that I can copy the incisal translucency. So let's look at a case. Here's a case of a previously placed porcelain veneer. And what we're going to do is take that veneer off, and I'm going to do a freehand composite. A lot of things wrong with this tooth. Tooth appears fat. Why? Because the line angles are out to the mesial and distal. The incisal edge does not look like the adjacent tooth, so we take that off. Now, how much preparation do you need in order to do a shade change? Well, for every shade change you want to do, you need 0.3 of a millimeter of reduction. So keep that in mind. If you're going from an A3 to a B1, you're going A3 to an A2, that's 0.3, A2 to an A1, that's 0.3, A1 to a B1, that's 0.9 of a millimeter. Your biomechanically may be causing problems with the flexure of that tooth. So here I put like a Dentin shade of composite. This is the hybrid composite, A1. And then what I want to do is look at that and see what's the value like. If that tooth is darker than the adjacent tooth, I need to brighten it up. And the way I can brighten teeth up is using opacers. Opacers are from Cosmo. You use these like a flowable composite painted on the tooth, and you light cure that. And you look to see, has it raised the value? These are Vita shaded composites. If I have A1, I use A1 opaque. If I have a C2 tooth, I'll use C2 opaque. And then I look to see what the value is. You can see it was raised. Then I'm going to place a more chromatic shade at the cervical. You can see here, this may be an A1. And then at the incisal, I'm going to place a lighter shade. And I'm blending this into the tooth, always looking from the incisal edge to see if I have enough room for my final composite, because I'm going to use tints here in that incisal edge, violet tints, in order to give it some type of translucency, light curing between each layer. And then I'm going to cover this up with an achromatic enamel. This is going to be a translucent enamel. This is called an incisal light. This is from Cosmo. It's a microfill. And then I start to finish and polish. I'll use my discs. I want to move my line angles in to copy the adjacent teeth. And then I'll use these carbide burrs and I'll use diamonds to create those developmental depressions. The key here is you want to use these burrs using an electric handpiece and turning the speed down low. Why? So that I can carve the composite. If I use an air driven, you're talking about a lot of destruction. Then I'll use some polishers. These are from Cosmo. And then I'll use a Jiffy polisher and some carbide burrs on the lingual. The final polish I do is I use an Enamelize on a FlexiBuff. Enamelize is a aluminum oxide polishing paste with a flexible disc. And this is immediate post-op, before and the after, and then the close-up of the smile. So, you know, when it comes to composite resin, it's really important that you practice a lot. You have to have the ability to be able to layer. You have to have the ability to know how to do the anatomy, because really the shape trumps the color. If you get the color perfect, but I didn't get the anatomy the same, it's not going to look good. If you get the color close, but you get the shape right, that's going to give you a better success rate. So you need to have both, but I would make sure that the shape is right. How about a class 4? Let's look at a class 4. What are the keys to a class 4? Well, it's a long bevel. Long bevel, about 2 millimeter bevel. Why? Because I want that to blend into the teeth. I'm not going to stop the composite on the bevel. I'm going to stop the composite past the bevel. So I over etch the tooth. I etch the tooth, place my adhesive, and now the first layer is a achromatic, like a white enamel. That's just going on the lingual, and it's not coming onto that facial bevel. Take a look at that. I don't want it to be on the facial bevel because it's going to be too thick. So my dentin needs to go on that bevel to block the gray shine through. If your composites are too translucent or gray, you're not using the right material. So I interscope this. At the incisal, after I interscoped it, I light cured the dentin, and then I put a translucent shade in between those lobes. So the dentin is coming short of the edge, then a translucent shade is going at the edge. Then I place my enamel shade over the top with some tints, light curing each layer before I put the tint on. So you see the dentin, there's my translucent shade, the enamel shade. I put tints on here. You cannot stop a tint on the surface. You need to stop with a translucent shade on the surface. So we go ahead and place our final translucent enamel. Now we go ahead, finish and polish using my discs. And then to create these imbrication lines, I'll use a fine diamond going across the tooth in low speed. Then I'll use a Jiffy polisher, enamelize on a FlexiBuff. This just shows the reflective and refractive zones. It's just a theatrical glitter, just for my own personal use. And when we get done, you can see we block that fracture line, creating the nice imbrication lines, and then the smile up close, and before and after. And I anticipate those lasting quite a while. This last case I'm going to show before we take questions was an interesting case. This to me would be an orthodontic case if I had to prepare the teeth. I would not want to prepare these teeth for porcelain veneers or even composite veneers. I told the patient that if I could do this with resin, she was 59 years old, I said, I'll do it with resin. But if I can't, you're going to have orthodontics. So as you look at this, I'm going to use that distal line angle as my line angle. I'm going to build the mesials out of these teeth. I'm going to build number 10 out facially, and I'm going to close the diastema on number 8. And I want to give it the illusion that these teeth are straight without prepping them. So I work this up on a model. I take an impression and I do this up with composite on a model to see, can I really achieve what I want to achieve? Because those are pretty crooked and it's out of alignment. That lateral's got to be built out to match the distal of number 9. So I etch the teeth, constantly putting strips in, etching, rinsing, putting my adhesive on, air thinning it, light curing it. And then I'm going to finish that a little bit before I go on to the next one. The key is when you're doing adjacent teeth, you want to have a smooth surface on the inner proximal. I want to have a smooth surface so that when I do the next one, when I put the composite on, I put a strip in at the last minute and I pull it through to the lingual to grab that composite and seal the lingual margin. But it's going to stick to this tooth. It's sticking here, but I can separate that with an instrument torquing that at the cervical. And here it is prior to the polish. And then we're going to go ahead and just use polishing system. And when we get done, we did all additive. This is augmentation versus amputation. Here's what it looks like from the front, before and after. Absolutely no preparation. The only preparation was the acid etching where we removed some of the enamel. And this was done strictly with one shade of composite. Before and after. Here it is from the lingual. So on that note, Kim, I'm about 8 minutes till the noon hour. I'm happy to entertain any questions that you might have, but I appreciate the opportunity. I hope that it was informative, and keep up the good work.
Thank you, Dr. Margeas. We appreciate that. Dr. Cooch, I'll let you jump in here first.
Wow. Bob, I tell you, you are such an inspiration to any dentist. I've really enjoyed, and thank you for sharing those cases. But I got to tell you, I kind of want you to remove that one implant. I want to see the histology on
it. Was that funny when I said that to him? And he was like, well, do you have this? No. He goes, then he laughed and said, just tell us the connection. That's John for you.
Yeah, that's, but you know, it's amazing because I think that we underestimate the power of composite dentistry.
Yes.
In terms of what we're able to do for people. You know, I think we significantly underestimate it. And you know, there's so much that we can do for people by just by using composites and doing that. And that it lasts a sufficient amount of time that we can get back in and do, if the patient, you know, wants more definitive restoration. But guys, it was just impressive, Bob. I thank you so much. And I can't wait to hear the questions.
Thank you. I see.
Yes, and we're getting a lot of comments, more so than even questions, just people saying, you know, such nice results on all of these cases, and loving the diagram representations that you gave. So thank you so much for that. We did have a couple, and as we're wrapping up and doing Q&A, if you guys have more questions, please go ahead and type them in the Q&A box as we're going through these. So one of them was, if this is acid challenge, and this was referring to one of the cases early on, but if this is acid challenge, what are you going to do where there is loss of enamel and dentin on incisal edges of lower interiors?
Yeah, if I have lower anteriors with a loss of enamel and dentin, what you have to do is, I still don't mind putting composite there, but if you put that on just the facial, it's going to break off. I have to almost make it like a taco shell, where I have to prep the lingual a little bit and get a margin, then I'm going to cap that whole incisal edge. And still, even then, you can still get chipping, but I'm going to try to wrap that on the lingual in order to get more of a compression type restoration versus a tensile force. But I will tell you, if I have enamel to bond to and that continues to break, I'll do a conservative veneer prep and I'll bond to the majority of the enamel on the facial, grabbing more tooth structure.
Excellent, thank you. We're just getting more comments, people saying that your work is really amazing. Another question, would you consider glass ionomer on the class 5 areas of erosion?
Yeah, glass ionomer is a great restoration, and I have had extremely good, successful restorations with glass ionomer. I like the new GC product, the Equia HT, the high translucent. The problem with glass ionomer is that the aesthetics is not as good as composite, but research shows that glass ionomers can last as long as composite in those situations, especially if you're bonding to root structure. The other one I like that has very good handling is Voco's material, like Iona Star and Iona Lux. Iona Star is a chemical cured glass ionomer. Iona Lux is just a light cured resin modified glass ionomer. So yes, I do like glass ionomers for class 5s also.
Excellent. I'd like to point attention to Kim's comment because I think it's so true. She said, dentists are such artists, and it is. It's really incredible work. I don't see any other questions, so if you have any more, please type them in. And as we close out here, thank you so much, Dr. Margeas, again, for fitting us into your very busy schedule. We do appreciate it. Before we wrap up, I wanted to let you guys know, so next week is going to be our last week of CONNEXT, so don't miss out. We're going to have to hold back the tears as we wrap up next week because this has been such a fun 5 weeks for all of us, and I know you guys have enjoyed it too, so thank you so much for being on this ride with us. We're hosting Chris Moriarty on Monday, so besides being quick-witted, dynamic, and super fun, he is also a nationally recognized speaker with 13 years of dental consulting experience, and he's speaking on relationship-driven communication tactics, and the title of his course is You Can't Help Anyone If They Don't Say Yes. So I think that'll be a really fun course to attend on Monday. So before we wrap up, Dr. Cooch, do you want to close us out? Any final thoughts or comments?
Oh, I just want to tell you one more time, Bob, how much I appreciate you and everything you do for our profession. And one of these years, I am actually going to get you out to the rendezvous.
We will make that happen.
And be safe and good luck with your travels, with your work as you reopen your practice, and I hope to see you at the symposium.
Thank you. Hey, Kendall, if you want to post a text, like if they text Bob, B-O-B, to 218-414-7597, I have a materials list that the participants can have, 218-414-7597. If you text Bob to that number, they'll take you to the site, and the materials list will be on that site.
That's awesome. I know people will appreciate that so much. So we'll get that posted. We'll post it with the recording so that people have that information. And we appreciate it. Well, thank you, everyone. Thank you, Dr. Margeas. Everyone have a wonderful weekend.
Yep. See you next week.
See you next time, Kim. Take care, my friend.